I work primarily in the field of reproductive endocrinology and fertility, which is a small area of gynecology. In this area, we work on hormone imbalances in women related to the reproductive tract, and we spend a lot of time treating patients with infertility. We stimulate ovaries with medications. We poke ovaries with needles to retrieve eggs. We do invasive things like put in speculums and insert embryos and sperm into uteruses. We see people also with hormone imbalances that mean they have irregular menstrual periods or heavy periods, too much facial hair or body hair, hot flushes. We deal with women during menopause or symptomatic menopause. Infertility can be caused by male factor, and we don't actually assess men other than to look at their sperm counts, but about 40% of infertility is related to male factor. But on the female side, things that we look at are tubal disease, so blocked or damaged fallopian tubes, and ovulation problems, meaning that you don't ovulate, or that you ovulate infrequently, or you have hormone imbalance like polycystic ovaries. Those are all ovarian problems. We also see problems such as endometriosis, which can be associated with pelvic pain and infertility. So I may be doing one role one day and a different role another day, but for example, one clinical day I might start as early as 7:30 in the morning and go to the clinic, and my job for the morning will be to do the ultrasound scans, which means that we have a number of patients who come in for monitoring of what's going on in their ovaries during an IVF cycle or during an ovulation induction cycle, which means they're receiving medications to get pregnant. And so my job for the day would be for the morning would be to scan these women, and that's perform a vaginal ultrasound on them to examine what's going on in their ovaries and look at their uteruses and correlate this information with blood work and other tests that we do to assess their response to what we're doing to them. We also do other imaging tests, so we might go to X-ray and perform specific imaging of their uterus and tubes, something called the hysterosalpingogram. And the reason I put the two things together is that usually you'll do an imaging morning a week, meaning you do ultrasounds, and then you go over to X-ray and do hysterosalpingogram. So we do that on the whole clinic's patients, so it's a team event. And then in the afternoon I might see patients in the office, both new and follow-up patients who present with these particular kinds of problems. The vast majority of my patients are very well educated, and they come in knowing a lot about their condition or thinking they know a lot about their condition from reading on the internet and from friends and colleagues, and there's just so much information out there that a lot of times the first thing I have to do is dispel myths and possibly refute what they believe to be true. But on the whole, people want to collaborate with you, they want to get better, they want to have a baby, and many of them are very compliant and hardworking and would do virtually anything reasonable that you asked of them. That if you relax, you'll get pregnant. That if you just relax, you'll get pregnant. Because a lot of people believe that they're not getting pregnant because they're tense or because there's a problem with stress, pressure, anxiety. There's also the myth that we can test for everything and explain everything that's going on, because there are many, many things in our field that cannot easily be explained. About 20 to 25% of the patients that we see have unexplained infertility, which means we do all the routine tests and we never can tell them, or we never can find an actual cause for them not conceiving, and yet they're not getting pregnant, so there's something going on. I think to do a broad-based background in sciences and consider social sciences, because human interaction is a large part of what we do in medicine, and people need to be aware of the soft skills